Look, it's now a great pleasure for me to introduce and hand over to Professor Michael Baker. I'm sure Michael is well known to many of us as the voice of science. He has sat there alongside Ashley Bloomfield, I think, right since pretty much since COVID came here, providing a very clear explanation of what was going on and what the issues around COVID that were impacting on the community. He very quickly became a credible voice, like I say, alongside Ashley. But he's not just academic eye candy. Michael has also had an involvement with harm reduction for decades. And I was fortunate a few years ago now to go to the inaugural harm reduction conference in Christchurch, which was hosted, I think, by the Needle Exchange. And a number of people who spoke acknowledged and mihi to Michael for the work that he did 30 years ago or longer to get the Needle Exchange program established and to advocate for harm reduction and looking after people who need that support. So just wanting to acknowledge Michael for the work that he's currently doing, the work that he has done. We're also very privileged to now have him on the board of the New Zealand Drug Foundation as well. So now I'd like to hand over, and Michael's going to tell us a bit about how the war on drugs has impacted our COVID-19 response. Kia ora, ka mihi over to you, Ewa.
Well, kia ora koutou. It's great to be here, and thanks to Ari for the introduction. I was delighted to join the board of the Drug Foundation because I've always admired it as a courageous, principled, and evidence-informed organisation. So it's really good to be here today. So I'm going to just share, being an academic, I can't resist PowerPoint. So I'm just going to share my screen now. Hopefully you can see that all right. And there. So the topic is the war on drugs undermining New Zealand's COVID-19 response? You probably know the answer, but I will get to that. And so what I want to do, and Tuari's mentioned about the last time we had a pandemic undermined by the war on drugs, and that was HIV/AIDS and injecting drug use more than 30 years ago. And I'll say a little bit more about that. And now we have a current pandemic undermined by the war on drugs, COVID-19 and the use of methamphetamine and other drugs as well. Why inequities matter with pandemics, as in everything else in the health sector. What would a harm minimization approach look like? And some actions we could consider now. So just to remind you, everything about pandemics, the core concept is epidemic, which is more than expected. You have localized outbreaks in global pandemics. So this is really the epidemic curve, which is just the incidence of something over time. And this was when I got I shifted down to Wellington. I was a registrar in various hospitals around Auckland, and I thought I'd have a year out in Wellington working for one of the ministers of health. It's quite a long story how I got to be there. And when I arrived there, HIV/AIDS was really hitting New Zealand and terrifying people. And it was one of those moments where people were looking for solutions. And the minister asked me to look into what we should do about the transmission of HIV/AIDS by injecting drug use. And a lot of this was really new to me. I was pretty green, I realize now. But I did get introduced through mutual friends to groups of very smart, principled injecting drug users who basically just introduced me to the idea of harm minimization and making needles and syringes more available. So that became my main activity while I was in the minister's office. And so this is, again, it was Michael Bassett, and there was already some work happening on the policy space. And we basically, the scheme was, the legislation was passed by an order in council, so it wasn't actually legislation, it's regulation. 1987, and it started on the 16th of May, 1998. So it's over 30 years ago. And this was actually the first national program in the world. So this is just showing the huge increase in distribution of needles and syringes through the program. So that's one measure of, I guess, accessibility, a bit like how we measure distribution of vaccines as a measure of success now with battling COVID-19. One of the remarkable trends over time was the switch from distribution through pharmacies to the rise of the needle and exchange programs and outreach workers. So this was the community actually taking control and ownership of this service. And that, I think, was a real turning point when it went from just provision of a service to actually active engagement and ownership by the community. So what is the impact of the NEP? Well, this is showing the HIV infections diagnosed in people with a history of injecting drug use. And you can see this is no history, and this is people with a history, and it's basically been a tiny proportion. So I think this program and the work of the exchanges and the whole sector, it's not just the NEP, it's everything that went with it, has been very successful in keeping HIV/AIDS out of this community, and obviously, resulting in big societal benefits as well. So if we, fast forward more than 30 years, we have another global pandemic, a different virus. Obviously, it's transmitted by the respiratory mode rather than in blood and other body fluids. And this, unfortunately, is what's happened in New Zealand. We had our elimination strategy, and now we've got this sustained Delta variant outbreak. So again, New Zealand has shown its ability to translate science into very progressive responses. And this was when New Zealand adopted the elimination strategy. It didn't use that word for quite a while. We used it, we wrote about the elimination strategy, but they really effectively did it by the announcement on the 23rd of March, saying we're going to move into the most intense lockdown possible with only 100 cases and no deaths. And around the world, people thought that was a huge call, almost a huge overreaction. And history, of course, has shown that this was absolutely the right thing to do. So this just to remind you of the countries in the Asia-Pacific region pursuing elimination strategies. Some have pivoted away, like notably Singapore from that. And this is like cumulative COVID-19 deaths per million people. And this is the countries of that we normally look to for leadership, Europe and North America, and the US and the UK, with obviously huge resources for pandemic control. And we can just see that they have been very unsuccessful in reducing the really quite appalling toll that this pandemic is taking on human lives and well-being. And what we're seeing in these countries is in the first year of the pandemic, 1 to 2 years of life lost, which is of life expectancy, which is a phenomenal impact. So one of the first lessons from this is the response is the critical need to focus on equity. This is just showing the earlier stages of the Delta variant outbreak in Auckland, where alert level 4 and was working very well at preventing widespread transmission, but it failed dismally with interrupting transmission in marginalized groups. And so at a certain point on the 4th of October, the government announced a transition away from elimination. They didn't say to what, but a tight suppression approach. And then the traffic light system came in, which was basically an indoor vaccine mandate. So the problem here was we didn't adapt our strategy for the fact that the virus was being transmitted in marginalized groups who are very poorly served by health services and very poorly connected with the prevention program. So this is another measure of equity. This is looking now at the delivery of vaccines to alcohol and drug service users and showing that we're really performing very poorly with delivery in this population. And the same concern has been expressed about low coverage in Māori, although there's a very active program to close that gap, and that is starting to succeed. This is showing the same data, just broken down slightly differently, looking at the general population, alcohol and drug populations, and then Māori and Pacific service users. And you can see with both first and second dose, we are not really delivering vaccine effectively to these groups. So the war on drugs doesn't work. I mean, we've had 50 years now of evidence saying that it doesn't work. And many of us, all of us, know the reasons about the fact that when we look at something like COVID-19, it thrives in stigma and secrecy. Criminalization makes it hard to engage with people, marginalized in the health system, the effects of heavy policing, and often I think just even low priority afforded to groups that are stigmatized and where there's a lot of stereotypes and prejudice. So really, these are some of the reasons why the environment we've created really makes it very hard to deliver services to this group. So what works? I mean, again, I'm sure many of you on this in this meeting will know what works because you're actually involved in doing it. But obviously, peer or other close relationships help to mediate the delivery of vaccines, testing, contact tracing, taking services to people rather than expecting them to necessarily front up to pop-up clinics and so on. Things like financial incentives and really co-designing solutions with people who use drugs and civil society, that's various government agencies. So it's more of a partnership model, and obviously trying to minimize the effects of police or council harassment, which may, again, drive a wedge between service provision and these communities. So what are some of the conclusions we can take from this experience? Harm reduction works, and we only have to look at our own experience in New Zealand. We can also look internationally. I think one of the things that's quite apparent in New Zealand's response to pandemics, it is very innovative. We did it with HIV/AIDS, and now we've done it with COVID-19 as well. We need to transition to a health-based approach. I think that's widely accepted and based on health promotion, health equity principles. Will obviously benefit marginalized groups. As we know, there's a huge societal benefit, which does very much, I think, it certainly helped in getting a needle and syringe exchange program set up. Basically, it had huge bipartisan support. And I think, again, we can achieve that by just making the case that there's huge societal benefits. Obviously, you need to have this ongoing dialogue between the communities of interest, service providers, government agencies. And I think we could make better use of our existing services, including the NEP providers in New Zealand. So there's obviously a lot of specific actions. I think we need a strategy for COVID-19 and people who use drugs. Again, this strategy could be refined through and co-designed with very active dialogue between the key parties. And I think this is where the New Zealand Drug Foundation really shines as a respected broker. And again, I think we can fund alcohol and drug services and NEP services to provide these services. And ultimately, decriminalising drug use as part of a harm reduction strategy has to be considered. I think that's a really critical step where I think there's a huge amount of support for what is a very logical, evidence-informed shift in our policy settings. So thank you.
Kia ora, and thank you, Michael, once again for a very, very informed and thought-provoking presentation that also gives us some very, very clear guidance as to where we need to be heading.
One of the questions is, are we seeing people who use drugs impacted by COVID-19? And are our vaccination levels where we need them to be to protect them? And if not, what needs to change?
Look, it's a good question. I think from the evidence we've got, yes to both of those, or yes to them being impacted and no to vaccine coverage being adequate. Really, to measure impact is quite difficult. I mean, we can get data on socio-demographic characteristics like age, sex, ethnicity, location, deprivation, and that does show that disease risk is patterned by the familiar risk factors associated with deprivation. But drug use is not consistently recorded in the system. And to make sense of the data, you'd need numerator and denominator data. I mean, anecdotally, I've heard, and Sarah Helm I think can comment on this in more detail, that we are seeing people who use drugs overrepresented in those admitted to hospital with serious COVID-related illness. Now, as I showed in my slide, there are some data on vaccination coverage levels in people who use drugs, and they are significantly lower than for most New Zealanders. So I think there's clearly a problem of accessing these key preventive services. But I might ask Sarah can perhaps comment.
Yeah, and I can also see James Halpin's question there from staff. Look, the vaccination rates are low, even amongst people who have addiction and are currently in DHB-funded treatment. So they're trailing something like 30% behind the general population, and it's much, much lower if you happen to be Māori and have an addiction. And so that's among the people that we know are in DHB-funded treatment. People who are experiencing significant drug harm or addiction or drug use, we suspect the rates are even lower. And what we know we need to do from the international data and from our mates who have managed to do it both in Canada, some of the people we were speaking to earlier, and from parts of the country where they have been successful, is put the vaccination right in front of the person and have somebody there to mediate the conversation. So what we badly, badly need is some funding put into our AOD services and our needle exchanges to enable those lowly funded organisations to be able to get alongside their service users. And what we also need is vaccinators to be located in the service. You need to be there then, right in the moment, to be able to vaccinate our most impacted communities. They're not going to rock up to a mainstream event, wake up at 10 a.m. and go, gosh, it's my day to get vaccinated. We need to handle it differently. And because we are seeing that significant harm impacting some of our most affected drug and methamphetamine users, we need to get in there right now. We don't have long before we continue to see COVID in other parts of the country. Kia ora.
Kia ora, and Michael, I might give you the opportunity to add anything if you want to James's question from Stuff. So his question was your thoughts on whether people whether there's been a failure to stop the spread of COVID amongst people who use drugs, particularly people who use methamphetamine, and what should be changed with the rollout. I know we've kind of touched on this already, but anything else you want to add?
Yeah, well, I think we've got objective and anecdotal data. I think there's good objective data that coverage is lower in people who use drugs, vaccine coverage, so that's a failure of delivery. But we've got very good anecdotal data that I think much of the failure to control the Delta variant outbreak in Auckland was related to problems of a strategy that was not reaching people in marginalised groups. And I didn't do the frontline work in Auckland, so this is secondhand information, but it did seem very apparent that we needed a change in strategy. We needed to refresh it. Alert level 4 controls, the alert level system was working well for Auckland in general. Go early, go hard model was extremely effective, but we needed to do something different, something additional, which was a highly targeted approach, which we didn't do. So that lack of adapting our response to the circumstances in Auckland, I think, has resulted in a huge price for New Zealand, not just for the affected communities, but for our whole society. And I think this is a huge learning opportunity from that experience that still applies now. I mean, those principles are still there, but the stakes have changed a bit. Now it's much more, as we know, with suppression, it's trying to minimize harm across the whole population. So it's very different from when we were, very close to eliminating the virus in Auckland.
Well, kia ora, Professor Baker. Thanks so much for your time again. And thanks everyone for all your questions. Unfortunately, we're running short of time. I've got to hand back to Ari to continue on with our meeting. But kia ora.